All right, guys, I am live. I am enjoying this time out here listening to some of my favorite music, throwback from the 90s with Third Eye Blind. Yeah, showing my age there, guys. Had to do it. Hey, guys, let me know if you can hear me. My internet is just a wee bit shaky, so I want to make sure I'm in the right place. But, I mean, look how gorgeous this is. Look how beautiful. Hey, Daniel. Hey, Karen from California. There's my California girl. There's Timothy. How are you, Timmy? Hey, Adam, I'm so glad you could make it. Happy hump day to you as well. Hey, guys, I am seeing you jump on board. If I look makeup free, hair free, and hopefully a little more relaxed, it's because I'm on vacation and I am loving it over here. Loud and clear. Glad you can hear me. Oh, thank you, Megan. Hey, Les, thanks for letting me know. Yes, guys. So if you've been watching, hey, Mark, that is me, Mark S. I'm glad you could join me, man. Let me tell you, Mark, loving it up here in Michigan, getting a break from that Florida heat. Hey, isn't it stunning? It is beautiful. Debbie, hey, girl, how you doing? I'm glad you could make it. There's my St. Pete girl. We've got Kim, you need my drink. Kim, let me tell you what, I've got the most awesome in-laws. My sister-in-law and brother-in-law are in there cooking up a storm. My brother-in-law made me this gorgeous pina colada. Yeah, I've been saving it until now. Oh, and guess what, guys? Those of you who know what this is, Smith Island cake. They brought me Smith Island cake. Chocolate. This is my favorite chocolate Smith Island cake. It is definitely vacation time when I've got my pina colada in one hand and my chocolate cake in the other. Hey, Brett, you're in Phillipsburg with your cold iced tea. You can hear me good. Hey, Diane, glad you could make it. Bonnie, there you are. Oh, so glad you guys could join me this evening. Yes, definitely. Everybody should have a good drink in their hands this evening. I want to hear what you guys are drinking. Hopefully no, I am not drunk, Mark S. Although it would probably make my answers a lot more interesting if I were drunk. But no, sad to say, I am not drunk. I have not had a sip of this yet, but I should probably start. So everyone, cheers. Cheers to those of you who are at home with an interesting drink in your hand. And for those of you who are not home with an interesting drink in your hand, go get one. All right, it's going to be a good show tonight. Thank you, Andrea. And guys, it's been a wonderful week here. I have to brag a little bit about this part of our country. I'm in Glen Arbor, Michigan. For my Michiganders out there, I've heard from some of you this week as you've seen my posts in different parts. What a beautiful part of our country. My mother-in-law always calls this God's country, and I have a hard time arguing with her about that. It's absolutely stunning out here. And as you can see, I have some beautiful backyard in the place we're staying. There was a deer here not too long ago, so let me know. We might see a little deer through here. The particular owner of this house has a beautiful vegetable garden over here, and the deer was sampling the goods. No, don't drink, don't smoke. I know I'm boring in that regard, my Mark. Hey, Jamar. Yes, I know. Yes, I know Haven is going to the Paralympics. And guys, I got to tell you, in August, okay, so we're obviously in the middle of all the Olympics and all the craziness going on with Simone Biles and Aaron Ledecky and all that kind of stuff going on right now. But then we get the Paralympics coming up in the last week of August and the first couple of days of September. And I will be teaming Amplitude Magazine and the one and the only John Register Paralympic system. We're going to be doing a 2-week special on the Paralympics. And let me tell you a little backstory on this one, guys. I was watching the Olympic trials. I'm a swimmer to run, so I love those. That's what I love to watch when it comes to the Olympics. And I was so excited this year to see NBC on the Peacock channel was really broadcasting the Paralympic trials, because if you guys have been watching my show, you've seen me with Haven Shepherd. She was a Paralympic hopeful, and she is going to the Paralympics on swimming. I believe it's 200 breaststroke, and I think she's doing the IM as well. And so anyways, I'm watching the Paralympic trials with my kids, right? And my kids have grown up coming with me to the clinic. They know about everything that I do. My husband's also in healthcare, we're family. So my kids are very comfortable discussing, disability. They're comfortable discussing, things about medicine. So they were asking me all these really wonderful questions about the different swims that they saw. They were saying, well, why is it that the person with one leg is competing with no legs, who's a bilateral amputee? Why is it the person who looks like they're okay. Why are they competing in the Paralympics? And explaining to my kids about the different kinds of disabilities that you'll see in the Paralympics and how they have different classifications as to how they judge the different levels of competition. And then also, for example, with the swimmers who are visually impaired, that they have a special guide so to prevent them from smacking into the wall as they do their flip turns with swim. So explaining all these things to my kids, and I realized there's not a lot, there's nowhere near enough knowledge about the Paralympics out there and about how hard these athletes have to work and what amazing athletes they are. I mean, some of these swim times, my kids are swimmers too. We were checking out their swim times, and these guys are swimming fast. So I was fortunate enough to be able to connect with the editor from Amplitude magazine. And we talked about this. So we're going to be bringing a 2-week special towards the end of August on the Paralympics and just talking about the different classifications and what do these things mean? What does it mean to be a Paralympian? And obviously we know Haven, for example, she's going to have her hands full. So I didn't even bother trying to call her because I know she's crazy busy. But John Register, who is a Paralympic silver medalist in track and field, he will be coming on the show. And he's been on the show before, and he's a wonderful, wonderful speaker. He's an above the knee amputee himself. He's a veteran from the Army. So, that's a soft spot in my heart for my veterans. So it's going to be a good 2 weeks. And guys, I'll be putting all this information on my website. All right, let's see who else jumped on board. Let's see. Oh, we got Diane Kingston starting rehab soon and we'll get your stubbies. Oh, wonderful, Diane. Diane, I really love it when my bilateral above the knees use stubbies in the first part of their rehab process. It's so important for building that core strength and helping you regain that center of gravity before you go on to using full length legs. So rock on, Debbie, rock on. And we got Jody, who got her new professorship in Las Vegas. Be teaching us math, right, Jody? Remind me if I'm wrong. Let's see who else we got on board. All right, guys. Lovely, Chuck. And guys, I am broadcasting. I always like to remind folks, I am broadcasting also from my YouTube channel. So for folks who don't have Facebook, it's a lot easier sometimes just to find me under Cosi Talks on the YouTube channel. So for those of you who might be recommending my show to folks, that's another place where they can find me. Hey, Gregory, this is the live show. Yes, you are in the right place. We're going to have a few folks here, new folks here tonight. So I'm so excited about that. Hey, compadre. All right, let's see. Who else? Hey, Harsh. Oh, you're here, Harsh, a little bit early this evening. I'm so glad you could join. And Jean. All right, guys, so let me just officially get started. Hey, Jill. For those of you who are new to the show, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist. Normally, I am in Tampa, Florida, where I have an outpatient clinic that is exclusively for working with amputees. But I am on a little family vacation here in the beautiful town of Glen Arbor, Michigan. And I just had to do this outside because look how gorgeous. All right, guys, I have been saving your questions all week on my phone, so you'll have to forgive me. I have all your questions stored on my phone, so I'll be referring to this. And let's just go ahead and get started with the first question. And folks, if you're new to the show, I love interacting with my audience. I love knowing who's out there and love answering your questions. So don't be shy. Put your questions in the comment section. Bring it on. Oh, first, cheers. Oh, that's a good pina colada. That's a good one. All right. This first question comes from Carl says, let me see if I can read this. I have not had a limb amputation, but I did have a nerve amputation relating to a neuroma, Morton's neuroma, in my foot. Now I have terrible pain from the neuroma at the excision site. I've heard about TMR and RPNI to treat this. I understand such a procedure would take place more proximally in my foot. Question is, which one would be more appropriate, TMR or RPNI? So guys, a couple of weeks ago, I had a phenomenal surgeon, Dr. Leonard Desi, come on the show. He's an orthopedic surgeon, and we talked about targeted muscle reinnervation and, regenerative peripheral neural interface, peripheral nerve interface. Okay, these are two procedures that are designed to treat neuromas. Okay, so just a quick overcap for those of you who didn't get a chance to listen on those shows. When an amputation is done, right? It's kind of basic. They slice through the skin, they slice through the muscles, and when they get to the nerves, they pull the nerve and they cut the nerve, and then they nerve to go back into the soft tissue, almost like an elastic recoil. The problem is when this nerve starts to heal, right, it gets a little scar tissue forming, it starts to try to spread out little nerve rootlets, and it starts to cause problems. Why? Because it's floating around in the soft tissue, right? Idle hands make devil's work. The nerve's job is to tell a muscle what to do. A nerve likes to be inside of a muscle, innervating that muscle, telling it what to do. So with amputation and that nerve is left flopping around, it's going to cause problems. And many of you have expressed to me that you have a lot of pain from these neuromas that can prevent you from wearing your prosthesis, and they can be really, really tricky to treat. Okay, and this can happen in folks even if you don't have an amputation, like Carl here, for example. He had what's commonly known as a Morton's neuroma. So it's a neuroma that's usually located in the, and a lot of times with these neuromas, a surgeon will simply take out or resect that little chunk of neuroma. Okay. Guys, looks like I'm having connection issues. Okay. Hey guys, can you hear me? Can you guys give me a thumbs up if you can hear me? Looks like I was having some connection issues. Hey Lonnie, hey Steve, glad you could make it. Good. Guys, can you give me a thumbs up? Not sure if I lost connection. Okay now? Okay. Thank you guys. Thank you, Kay. Thank you, Mark. Okay. So even in folks who don't have an amputation, they're dealing with neuromas, same thing, it gets excised. So with the targeted muscle reinnervation, what they're basically doing is they're taking the end of that nerve and they're plugging it back into a muscle. So basically they're giving it back its job. So it makes the nerve happy and it makes the patient happy because they don't have pain anymore, okay? Now there's a sister, I call it a sister procedure because it's very similar. It's called RPNI. So basically, instead of pulling the nerve directly into the muscle, they might take a piece of the muscle and wrap the nerve, wrap it around the nerve. And it's the same concept. It's giving that nerve something to do. Okay, so with our surgeon, what I really loved about having Dr. Dedesi on board last week is that he does both. He does TMR and RPNI. Now, there's not a whole lot of surgeons out there who do these procedures, but when you find a surgeon, usually one will favor one procedure over the other. You have some surgeons that say TMR, 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 and you have some surgeons that say RPNI, RPNI, RPNI. Wow, I said that 3 times fast. Okay. So basically what Dr. Dedesi says is when he goes and he opens the patient and he sees what he's looking at, that's when he makes the decision as to whether he does a TMR or an RPNI. A lot of it will just be determined by what kind of a nerve is he looking at. How much of a graft does he need from that muscle? Can he get away with doing an RPNI, meaning just taking a little piece of muscle graft and wrapping it around the nerve? Or does he need to find a big juicy muscle and plug the nerve directly into it? So if this is something that you're thinking about doing, I would go and find a surgeon who does both procedures, honestly. Honestly, any of the surgeons who do any of the 2 procedures, you're going to be good to go. But if you're fortunate enough to find yourself a surgeon who does both procedures, that's the person I'd go talk to and just see what they would recommend for you. Outcomes are very good in both procedures in terms of relief from pain. And for many of Dr. Dedesi's patients, he's mentioned that also relief from phantom limb pain, because sometimes these neuromas will trigger the phantom limb pain. All right, I'm talking too much. Let me read some of these comments that have been coming in. Hey, we got Teresa on board this evening. I'm glad you could make it. There's David. I was looking for you, man. Andrea says connection issues. Okay, good. So hopefully my connection will last. You know what? I think if I take another sip of this, my connection will get stronger. It's good stuff. All right, guys, go ahead and put your questions in the comments section. All right, let's go on to the next question that came in. This is a good one. This person says, I have an issue. My knee is messing up. They didn't use that word. All of my long pants. Is there a solution to this? Okay. And I've noticed this, guys. This is something. Hey, Tom, there you are. I haven't seen you in a while. So apparently and this can happen with both with below the knee patients and above the knee patients. With my below the knee patients, that lip of the prosthesis, those trim lines can really tear up the pants. And with my above the knee patients, it's their knee getting caught and pinching off that pant and rubbing it and putting holes in it. So if you're a below the knee patient, okay, first of all, go to your prosthetist and just see if they can smooth out those trim lines. Sometimes they can be a little bit rough, and sometimes the prosthetist can heat them up, smooth them out a little bit so they're not quite so rough and rubbing against your pant legs. The second thing is, and this is because this comes from my days of sewing, my mom teaching me how to sew on the sewing machine and all that kind of fun stuff. They sell patches, guys. They sell, and they're about this big, right? And I used to put them on the inside of my kids' pants because kids also tear up the knees on their pants. But these patches can really save your pants. They're about this big, and you sew them on the inside of the pant. And sometimes you can even iron them on to the inside of the pant. And that can really save the life of your pants. Okay. But I'd like to know from you guys, because I know probably you all have some really great hacks as to how to prevent your pants from getting torn apart. All right. So I want to hear some of those in the comment section right now. Let's see. Kim asks, is a neuroma surgery considered a revision surgery? That's a really great question, Kim. Yes and no. So what usually happens is a person is going to the surgeon because they have this neuroma that's really bugging them and really impacting their quality of life. And the surgeon will say, yep, you're a candidate to get this neuroma resected. Now, if the person has a massive scar tissue, or their scar has become invaginated, meaning it's like curling in, it's creating a crevice. If the person has excessive soft tissue, like they have a really fleshy end on their residual limb, then the surgeon is going to take advantage and resect that neuroma or do the TMR procedure and do the revision all at one time. Okay, and I see it done all the time, Kim. And then it's also the opposite end, where the person might be going to get a revision done because they have all that extra soft tissue, because they have scar that's really bothering them and it's not healing properly and it's not allowing them to wear a prosthesis. And in the process of doing the revision, the surgeon will do TMR in the nerves that are in there. So Kim, this is something that I really like to really put out there to my viewers, because many of my viewers have 2, sometimes even 3 revisions done, or they know that they're going to have an amputation. So they have just a little bit of time to research and ask their surgeons about this. If you're going in for a revision, even if it's not due to a neuroma, I say it's worth asking your surgeon about TMR surgery. I say it's worth it. They're already going to be in there, right? And if it's the orthopedic surgeon, and there's several kinds of surgeons that can be trained in the TMR procedures. Okay, so if you're having a revision done, now's definitely the time to ask your surgeon about TMR or RPNI. Okay, because if it's not a problem now, it could become a problem down the line. And again, guys, I would encourage you, skeeters, I would encourage you to look back on the video I did with Dr. Dedesi. And once I'm done, I'll post the link to that video in this particular video post. So Kim, you can go back and take a look at that. Okay, so you can really learn more about the TMR procedure. But if you're having a revision done, ask your surgeon about this. And Dr. Dedesi said it in the previous video. If your surgeon doesn't want to talk to you about this, you need to find a different surgeon. There, I said it. So Diane asks, I got a bad hematoma that had to be opened up and dug out. Is this common? Yes. Sometimes, so, but guys, basically hematoma is just a fancy word for bruise, right? You have blood vessels underneath the skin and the blood just pools and sits there. Now, usually within, your average bruise, over the course of time, that blood will break up and it'll siphon out and it'll go back into your system and everything goes away. But sometimes the blood will just sit there. And if you have poor circulation, if you have any swelling, the blood may not necessarily get filtered out of there and it just sits there. And it can become a problem in the sense that it can become very painful, or it can get hardened. And that's when it starts to become a potential problem. So yeah, sometimes if it's bad enough, sometimes surgeon will, or a doctor can go in there with a syringe, for example, and with a simple syringe, and they'll draw the blood out, the excess blood out. In some cases, they do have to make an incision to evacuate. They call it evacuating a hematoma, and to really, pull it out of there. All right. So yeah, sometimes that does happen. The question is, how'd you get that kind of a hematoma, Diane? Let's see. Joe says, I wear shorts so my pants don't get torn up. I know, Joe. And I see that. And I have to say something on that, because for me, I'm like, whenever I see someone who, I see that often in my patients, that they'll say, well, I just won't wear pants because it's just too much trouble and they get torn up. There are solutions out there, guys. There are solutions. So if you're somebody who really wants to continue to wear pants, again, try those patches. You can find them at, for us, it's our Joanne Fabrics down south, the local fabric store. And you can buy those patches that you can sew on the inside of your pants. And it saves the life on those pants, let me tell you. Oh, Stephen says, welcome to my home state. My stump is feeling better. I hope so, Stephen. You gave it a good bang there. Let's see what else we got. Okay, Megan says, that's a very good question, guys. Good questions about these neuromas. Is a neuroma visually located? Can you see it? How is it diagnosed? No, it's not something that you can visually see. Usually with my own patients, what sets off red bells in my head is when my patient comes in and they're just like, I have this incredibly sharp stabbing pain, okay? Or this sharp burning pain. Okay, that's very typical of nerve pain, right? And usually my patients will be able to say, it hurts right here. And they can really most often pinpoint where it hurts. Usually they start feeling this neuroma when they start wearing their prosthesis more, and the prosthesis just happens to be pushing up where that neuroma is, okay? And that's usually what gets it triggered, okay? And usually for me, and again, guys, as a physical therapist, I don't have access to prescribing x-rays or MRIs or anything like that, so I have to do all my diagnosis with my 10 fingers, right? So usually when I get my thumb and I push in where the person is complaining of pain, they'll see stars, okay? And that's usually to me an indication of, okay, there's either a neuroma here or there's a bone spur, okay? One of the two. And at that point, I usually, if they haven't already been evaluated by a doctor, I'll send them back there to their doctor to see if we can get some sort of a visual diagnostic just to see, what's going on. An x-ray will show you a bone spur, okay? So it'll show up pretty quickly if there's a bone spur there. And usually it's either an ultrasound or an MRI. Can you guys see me? Oh dear. Oh. All right, guys. Not sure if you guys can see me or hear me. Okay. All right. I think we're good. I think we're good. Okay, I'm back. Tom, thank you so much, because I cannot see the comments right now. So Tom, thank you for Thank you for sending me that message, Tom. All right, guys, I'm going to keep talking and hopefully you guys can see me. So we were talking about neuromas and how you can find and diagnose the neuromas. So again, me with my 2-thumb diagnosis, basically I just go in there and I push in on the area where the person is complaining of pain. If I push in on it and they go, yep, that's my pain, then that's the point I send them out to the doctor, and the doctor can tell me if it's a bone spur, a neuroma, or maybe something else. Okay, maybe there's just a little bit of scar tissue in there that needs to be worked upon that's also causing that pain. But obviously knowing what it is helps us treat it. Now with treating neuromas, guys, usually we try the conservative stuff first. We try to see if there's any modifications that could be made to the prosthesis. Will a liner, a different kind of liner, for example, a polyurethane liner that's really good at alleviating pressure, would that help with the neuroma? Maybe just even a modification to the socket if that area can be alleviated with pressure. Every once in a while, I have a patient who goes to a surgeon or a doctor who can inject that neuroma. Sometimes it works, sometimes it doesn't. And if we have absolutely no other option, then we send them to the surgeon to see about seeing if they are a candidate for revision surgery. Okay, but we usually try the conservative stuff first before we, send them back to a surgeon. All right, guys, let me see if I can get. It is way too bad I cannot see my questions. Hang on, guys. Let me see if I can do this, because right now I am flying without being able to see your comments right now. All right. All right, guys, I can't see your comments. So if you have any questions, go ahead and send them to my Facebook Messenger account, and I'm going to see if I can't try to get them during the show. All right. Next. Ooh, here's a good one. So Kenny asks me, I have drop foot on my right side, from a fusion that I had on my lower back. And then I'm below the knee on the left side. Okay, so the prosthetist is getting me an AFO brace. Any thoughts on whether I will get this back? Okay, so let's talk a little bit about this, guys. So this particular gentleman is a below the knee amputee on one side, but on the other side, he has nerve damage that has caused a drop foot. So what that means is you have muscles that lift your toe, right? So as you're walking, these muscles prevent you from stubbing your toe and dragging your foot, right? They're called your tibial muscles, right? On the front part of your shin. Now, when you have nerve damage in the lower leg, sometimes you'll get what's called drop foot. And it's basically that, where your foot is basically just dropped and it's kind of dangling. It doesn't have the ability to dorsiflex, to move up. Okay, so obviously the problem becomes is that you have a foot that's dragging on the ground and you can't pick it up, and you're going to be stumbling and losing your balance. So during this time, one of the treatment options is a prosthetist, or an orthotist, better said, will give you what's called an AFO, an ankle foot orthosis. And it's a little brace that goes underneath your foot and up the back of your calf, and it keeps your foot in a dorsiflexed position. Okay, so it keeps it fixed that way. The question is, can a person recuperate after having this kind of nerve damage? Okay, so this particular nerve damage came from a lower back surgery that this person had. So theoretically speaking, and again, without examining this individual, it could mean that the nerve damage came from his back. Okay, and this was actually a very interesting thing that Dr. Dedesi spoke about on the show, is how long does it take for a nerve to regenerate? Okay, and I think it's a 1 millimeter. It's a very slow progression. So the further up the damage, the more that nerve has to recover. Does that make sense? So if this person's damage came from their back, that means they've got a long ways to regenerate that nerve all the way down to the foot. Okay, and a nerve in about the first 18 months, that's when you're going to see the most return on nerve damage. Okay, so chances are, and that's why people who get drop foot, it's very difficult for them to regain that, because the nerve has to regenerate from pretty far up. So if this person is this far out from their nerve damage, it may not recover very much. Okay, and one of the ways that you can find out also is something through nerve conduction studies. Okay. And sometimes the neurologist will do this. Sometimes the physical medicine rehabilitation doctor will do this. Okay. And this is where they check to see, is the nerve damaged? How much is the nerve damaged? What kind of damage is done to the nerve? And that can give them a bit of a prognosis to see how much that they can possibly and reasonably expect for this nerve to recover, if at all. But the nice thing, the silver lining on this is with drop foot, with wearing an ankle foot orthosis, it's very easily corrected. And I've seen many, many people that they can walk quite efficiently with that ankle foot orthosis. And it's a simple brace that goes into their shoe. Okay. All right, let me just see. I think I have all the questions. And guys, I do apologize. It looks like my chat section here never came back with my reception. So I can't see what you guys are saying right now. But guys, I'm going to go ahead and wrap it up for this evening. If I missed your questions, I will go back, and when I get better reception, I will go back and look back at the questions just to see what questions I missed. For those of you who are watching the show for the first time, thank you again for watching and welcome. Guys, you can find me on my YouTube channel, my website, cositalks.com. You can follow me on Instagram. Don't be shy. Send me your questions. I love answering these questions for you guys. All right, guys. Next week, I will be back in hot, sunny, sticky Florida, and we will see you next week. Same bat time, same bat channel. God bless.